Greetings. My name is Howard Nussman. I'm a member of the consulting team at MSL Healthcare, and I have a special guest with me today. Her name is Jill Bruce from Southern Illinois Healthcare. I've spent a lot of time in Southern Illinois with Jill and the team at SIH with regulatory readiness, and she and I have done a lot of credentials review sessions together in mock surveys. So as I travel around, I've asked lots of organizations whether or not they have implemented the Joint Commission's and CMS's the allowance, I guess you would say, or have they implemented a 3-year credentialing and reappointment process since CMS announced back in 2022 that they would accept that. And Jill's one of the first in SIH, is one of the first organizations that I've come across that have implemented a 3-year reappointment process. And so I've invited her here today to talk with me about that and share with you how they went about that process. So Jill, welcome. And why don't we start off, just give everybody a little bit of an orientation to Southern Illinois Healthcare, what's your system, how large it is, how many hospitals, whatever you want to tell us about SIH.
Okay, sure. Thank you so much for inviting me to do this. I'm really excited to talk about the processes that we went through. So Southern Illinois Healthcare is located in the southern tip of Illinois. We are about 5 hours south of Chicago, about 2 hours from St. Louis, Missouri. We have 4 hospitals in our system. 3 of the hospitals are Joint Commission accredited, and 1 hospital is a critical access hospital. We have about 700 providers on staff, a mixture of course, physicians and mid-levels. We also have an employed group. So we have about 300 providers in our employed group, which consists of about 30 different clinics in Southern Illinois area. We have a level 2 trauma center. We are a level 2 trauma center, and we also have a behavioral health unit at one of our facilities. We are not a unified medical staff, so we have 4 separate hospital licenses. But we do have only 2 boards. So because of that, we have 1 set of bylaws that takes care of 3 of our hospitals, and then another set of bylaws that takes care of the other hospital.
Okay. All right. And I see a lot of that sort of in between, transitioning with systems as they're adding hospitals. All right. Well, then let's start off with just tell me a little bit about, how you came to the conclusion that converting from a 2-year reappointment cycle, to a 3-year, what the benefits would be and whether you could even do that or not at SIH.
Right. So there's a lot of factors that you have to keep in mind, of course. But, CMS made the change in November of 2022. And then the state of Illinois made it effective in January 1 of 2024, allowed all hospital systems in the state of Illinois to go to a 3-year reappointment cycle. So when the law changed, when we found out in January that the law had changed, that's when we started formulating a plan, meeting with our C-suite leaders, and just trying to get our ducks in a row to make this happen.
Okay. And that's an important point about the state law. Because, and in fact, I, just looked this morning, and even on the CMS website, when I went to look at the state operations manual, the wording says that that CMS recommends a 2-year reappraisal and reappointment process. And there are many states that the laws require a 2-year reappraisal and reappointment process. And so that is important, like to check and see, whether your state will allow you to go beyond a 2-year time limit on reappointing and reprivileging physicians and other practitioners on your medical staff. Because there are some that still, I'm in North Carolina. And North Carolina, as I understand it right now, still requires a 2-year. Next door, 15 minutes from me, is South Carolina, and they don't have a requirement. So you could make a 3-year change. So that's a very important point. What kind of reaction did you get from the medical staff when you started talking about changing the reappointment for them?
Oh, all I had to say was 3 years versus 2, and they were all on board because, providers, they're busy seeing patients. They don't have time for paperwork. They were 100% on board. The person that was most excited, though, is my credentials chair, because that reduces the workload for all the files that they have to approve and everything. So I absolutely received no pushback at all.
Mm-hmm. Mm-hmm. Okay, good. And so the primary motivation then behind it was reduced workload?
Yeah, the primary motivation, I think, of course, is the reduction in workload. That's number one. Provider satisfaction, of course, is primary too. And just streamlining processes. Nobody wants to do busy paperwork. We're already keeping our expirables up to date. We're already doing our ongoing query with the National Practitioner Data Bank. And we have a good peer review process. So we're already looking at the quality of care of our providers. So it's a win-win for everyone, honestly.
Mm-hmm. Okay. And just for the benefit of our listeners, so you have a centralized credentialing office, right?
Yes, that's correct. So we have a centralized credentialing office. So we take care of all 4 of our hospitals, but we also did within the last 5 years, is we also merged our payer enrollment managed care team. So we merged that group as well with our medical staff office. So when we are reappointing or even initially appointing a provider, we're not doing duplicate work. So we send the provider one set of materials that encompasses the hospital, that encompasses the employment side, and that encompasses the enrollment with Medicare, Medicaid, and the commercial payers. Mm-hmm. So the provider only has to do one thing. So it's just another example of how we've streamlined processes through the years.
Mm-hmm. Okay, that's excellent. And just out of curiosity, so how large is the medical staff office? How many people do you have that work with you in the reappointment and the reappraisal process?
I have 9 people on my team. So some may say, wow, that's a lot, but no, it's really not. Because we take care of licensure, we take care of malpractice insurance, we take care of enrollment with all the payers, of course, and then all the hospital credentialing, the executive committee meetings, everything that goes along with all that.
Mm-hmm. Okay. Yeah. So it's covering 4 hospitals plus
the employment side, because a lot of our employed providers, they're ambulatory providers, meaning they're office only. So that's another good point to make, is that since we are delegated with all the commercial payers, in the past, when we were on a 2-year cycle, we reappointed the office only providers every 2 years, when technically NCQA requires every 3 years. So we were actually doing more work than what we needed to do, but it was a good way. We still were streamlining the processes. Mm-hmm. So now that we've gone to a 3-year cycle, it works for everyone. So we're not doing anything extra.
Okay. All right. Excellent. Well, why don't we shift gears for a few minutes? And so let's say we have listeners who are now thinking about moving from a 2-year to a 3-year reappointment cycle. So just kind of talk us through the steps that you went through to get there. What would be the first thing someone should do?
Well, the first thing you need to do is, of course, get buy-in. Because if people don't want to do it, if your leaders don't want to do it, your physicians don't want to do it, you might as well just stop because it's not going to work. So once you have buy-in, then you need to consult with your general counsel. I'm at an advantage over maybe some other hospital systems because I've been within the organization for 28 years. So I pretty much know a lot of the key contacts, so I can...
Well connected.
Yeah, and I make it sound a little bit easier than it really is. Like, I understand some hospital systems are very convoluted and it's really difficult to jump through all these hoops. I do think it's worth it in the long run if you just stick with it. But, of course, consult with your general counsel. You need to formulate a strategic plan. Like, you need to make sure your bylaws are changed. And you need to make sure that your credentialing policies are updated. And if you're delegated, your managed care policy. So you need to make sure you remember all those factors. And communicate. Talk about it at your MEC meetings, talk about it at your credentials meetings. Make sure you're thinking of everything that might come up during that process.
Okay. So you have 2 sets of bylaws, since you have one for the 3 original hospitals. You added one a couple of years ago, probably
Right.
about the time that all this was, just getting started. So they haven't yet converted over to yours. I mean, is it as simple as just finding where it says every 2 years and change it to a 3? Or were there other places in the bylaws that you saw that there were impacts that you recall?
It kind of is that simple, honestly, if you think about it. But then that's a good opportunity for you to really look at your bylaws to see if anything else needs to be changed. Because I'm sure anybody that's in the medical staff profession knows it is very difficult to change bylaws. If your bylaws are written like ours are, there's a notification period that you have to give to all the medical staff members. Like, it's not as easy to change bylaws as it is to change rules and regs or a policy, for example. So I would take the liberty at that time to make sure your bylaws are completely up to date. Make sure you've done all the changes, that are needing to be done, because it's not something you want to do just every other month.
Okay. And then how about medical staff policies? Did you have many of those that made reference to every 2 years that needed to be modified?
Yeah, we only had a few. So we had our main credentialing policy, of course, and then we had an APP policy that we had to do some updating, and then we also had to make sure we changed our managed care credentialing policies to reflect the 3-year. So just kind of cross-reference, do a search for all of your policies, make sure, anything that says 2 years, you're making modifications so you don't forget something. The one thing that's important to know, and you might get to this later, but I'll mention it while it's on the top of my mind, we did not change 2 things. So we did not change our OPPE process. We kept that the same. We're making some changes with our OPPE right now. So we decided to leave it the way it is. And then we talked to our department chairs, our service line chiefs, and we didn't make any changes to our privilege forms. They still wanted to keep the previous 24-month log. The only thing that I think is going to be a little tricky, so we just started this, like I said, in the latter part of 2024. So the only thing that I think we might have a little bit of trickiness is we require certain CMEs at reappointment time.
Right.
So like trauma CMEs or pediatric, different things like that. And so our privilege forms, some of them say, like for trauma, for example, 10 CMEs a year. So we need to think when we're doing a reappointment, we're going to have 30
Surgery.
trauma CMEs, so we need to communicate that with our providers to let them know, hey, you got to continue on your same cycle, so they're not shocked at reappointment time.
Okay. Yeah, I would imagine there would be some of those sorts of things that as you go along, you might even discover, oh, well,
Yeah.
we didn't like think that through completely. So that's
Right.
good you point out.
Like, it's a learning tool for us. It's a learning curve. So you should probably have me come back like for a part 2.
Yeah, well, I was already thinking, we should do one of these sessions on OPPE. Yeah, because a lot of people are struggling with that.
Yes, yes.
And maybe have several of you, different organizations, share the approach to OPPE. And now on the privilege form, so what you're referencing there is, so you have some requirements, some criteria that are spelled out on the anesthesiologist set of privileges that specifies some volumes or whatever. And they were for 2 years?
Yes. Yeah. A lot of we specifically list a number for reappointment volume for case volumes. Okay. And it always reference the last 24 months or something like that. And so when we talked to our leaders, it was kind of like, well, what's the benefit of going 3 years worth of volumes when really we want to know what they've been doing the most current 24 months. So
good point.
Yeah, that was and plus that's easy because we didn't have to change privilege forms. So I was all on board with that.
So was it because it was easier or because it made sense?
It was a little bit of both.
All right. But that does make sense, in extending the reappointment cycle, that it is still the most recent history. And so I see the logic behind staying with. How many of these have you done, and what's been the experience as we've measured this over the past 2 years, even though we extended?
Yeah, because that's the most important thing. Like we're all about patient safety and quality of care, and so current volumes speak loudly.
Mm-hmm. Yeah. Let's see. So you talked about getting buy-in. Did you happen to have a particular physician who, just really championed the cause for you?
Yes, my credentials chair. So he is he speaks loudly, and so he really thought this was a good idea, not only for the reduction of workload, but just like it just made sense.
Mm-hmm.
It just.
Mm-hmm.
We're healthcare we're so busy and there's so much paperwork, and a lot of times providers, they feel like secretaries more than healthcare providers, and so this just makes sense for all of them.
Yeah, absolutely. I can see that. All right, so talk to me a little bit about so everybody's accustomed to a 2-year cycle, and just to clarify and make sure, so the fourth hospital that has a separate set of bylaws, you have been through the process of getting them transitioned, so that as practitioners from anywhere at SIH go to that hospital, they're covered on the same credentialing cycle.
Yes. So that's what we did. So if there's a provider that is on staff at all 4 of our hospitals or multiple hospitals, including the brand new one that we got, we transitioned all of them to be on the exact same cycle. So we're reappointing once, even though it's going to a different board for approval. Right. It's still on the same cycle, but you really have to. You have to be on your game because it's a tricky play on timeliness because there's a different board meeting. So you have to make sure that you're timing your reappointments based upon the meetings. And don't ever forget about that other hospital out there that has different set of meetings, you know?
Yeah, I'm sure that's a challenge.
Yes.
And at some point, I'm sure you'll get them into the fold and it'll all be the same. But
That's the goal.
takes time. But
Yeah.
I've worked with multiple systems, and as they add new members, it does take time. Let's see. So, and is it birthday, or can you decide with that
Yeah.
reappointment?
So we, I don't know, 10 plus years ago, we converted all of our providers to reappoint on a birth date cycle.
Right.
So that also helps streamline the workload. So there's a consistent number of reappointments that need to be processed every month. So what we did, the law in Illinois changed January 1. We started working on our bylaws and our policies. So we timed everything to go to the board. I think it was like June or July or something for final approval. So then what we did was we set a date to start this plan. So we set a date, August 1 of 2024. So any reappointment that went into effect on August 1 was then for a full 3-year term.
Okay.
Because those providers were already on a birth date cycle. So it already was working that way. But then any initial files that were approved after August 1, we would try to get them on a 3-year cycle. I would say probably 9 out of 10 of those providers were still on a 2-year cycle just because of the way the birth date and their start date landed.
Okay.
So even this, as we're doing this we're doing this in the latter part of 2024, those providers were still being reappointed in 2 years anyway, but then thereafter they will be for a full 3 years. But there's always a transition period. Even when you did the 2-year cycle, there were times when people were reappointed within like a year and a half just to get them on the right cycle.
Okay. All right.
Yeah.
So let me see if I understand. Because just takes me a while sometimes. So you picked a date, August the 1st of 2024.
Mm-hmm.
You said, all right, starting on that date, anybody that we reappoint, they will have a 3-year, it'll be their birthday 3 years out.
Correct.
New initial appointments starting on that date. You can't just say, well, it's because August 1st, that date that they come isn't necessarily their birthday.
Right.
And so some of them still just got a 2-year appointment because you had to get their reappointment cycle adjusted to match their birth date.
Correct.
Okay.
Yes. Yeah. Yeah. And actually, I looked it up, and between August and December, 29% of the initial appointments that we did were on a 2-year cycle. And then even now in 2025, I ran the numbers, 100% of them are still on a 2-year cycle. It's just, it's only because of the birth date issue. Because of course, Joint Commission, you cannot go over 3 years. So you just have to be really cognizant of that.
Right.
But it was funny because when we were doing the transition on August 1, you're working on your reappointments and you're doing your paperwork in advance of the effective date of August 1. So like you had to keep your mind going thinking, okay, I got to remember August 1, it's for 3 years. Or even like, so we say we had an initial that was approved on 7/30 of 2024. Well, that was still for 2 years.
Okay.
So you just, I don't know. You have to. So
you're going to be schizophrenic for a little while.
Yes, but that's okay. I already am.
Yeah. And so which now do you have an electronic credentialing system that you use?
Yes, we do. So we have Echo credentialing that we use to do, and we do online reappointments and online initial files. But the figuring out the dates is still a manual process.
Yes. But once you get them into the system, it does help you a little bit
It does.
in
Yeah.
terms of the schedule of, okay, when does Howard come back up for
Yes.
reappointment?
Oh, definitely. Yes. Because we run reports and that helps us figure that
Yeah.
out.
Yeah. Do you think it'd be possible to make this transition if you didn't have the support of an electronic credentialing system?
It depends upon how many providers that you have. But honestly, I don't even think our job is possible now without an electronic system.
It
I
does
just
do
think
a
we're
lot for
so,
you.
yeah, it does a lot for us as far as like continuous query and reminders. And I can't even imagine going back to the old fashioned way.
Mm-hmm. All right. And so do you know at what point in the future everyone will be on a 3-year cycle? You will have gotten through those people who were in the get transitioned to your birth date period.
I think in 2027, for sure.
Okay.
Yeah.
All right. And now, given that you have to balance, you have to keep in mind you have two systems, a 2-year system and a 3-year system running simultaneously in this transition. One of your goals was to reduce your workload. In the transition period, do you feel like it's reduced your workload or increased your workload, or is it just a matter of you have different things to think about?
I think you just have different things to think about because you're right. Right now, at this point, the workload is not mitigated. But I think that would happen in anything. Like there's a transition period that you have to go through. But I think as the years go on, most definitely,
Once you get to
we'll see the benefits of it. Yeah.
Okay. All right. I'm sure your CFO has probably got that date marked on his calendar or her calendar. It's going to
Yeah,
call you up and
definitely.
say, all right, what are you giving up?
Right. No, because we'll find something else to do.
You'll find something. Yeah. And so was there ever a day when you said, why on earth did I decide to do this?
Of course. I mean, I'm the type of person, and everyone in my office will make fun of me, but I have these wild ideas and I can go to A to Z, but I forget about all the things in the middle. I just know what the end result is, that my vision,
Mm-hmm.
And so of course, we were thinking, because we ran some future reports and we're thinking, oh my gosh, are we not going to have anything to do in 2026? But I still think it's going to work out. I still think, there's always new people that are coming in and then they won't be on a full 3 years. So again, that's where our part 2 meeting is going to come into play.
Yeah. So, yeah, I guess, because it's the same way if it's a 2-year, they're using the birth date rather than what was the anniversary of you getting appointed here, always creates a less than credential.
Right.
For certain. Yeah. For some
and that will always happen forever, that will, unless we change the way that we do our cycle. Like if we do another cycle and not by birth date, like if we would do something different.
Mm-hmm. Yeah.
And we had kind of thought when we were doing our planning, we had kind of thought about doing like a staggered approach, just so we would still have a consistent amount of reappointments. But I'm a lean thinker, and that was just too muddy for me. Like I can't do that. We need to have a set way to do it, and then just be consistent, and that required too many brain cells.
All right. So for someone who is thinking about this, implementing this, any words of wisdom that you would give to them?
Yeah, I've been thinking a lot about this. So first of all, of course, you have to follow your state laws, because just because Joint Commission and CMS are on board with it, if your state, like you mentioned, North Carolina, if your state doesn't allow it, well, you can't do it. So make sure you always check with your state laws. of course, check with your general counsel. If you have a CVO, make sure you're communicating all this. Like, we don't have a CVO. We kind of act like a CVO. So make sure you're communicating that to everyone. If you have a separate payer enrollment department, by all means, I am a big proponent to merging the payer enrollment and medical staff activities because I think it's duplicate work. But definitely communicate with them. Keep in mind, I would say probably most hospital systems sign up for continuous query with the data bank.
Yep.
But if you don't, and if you're doing it every 2 years on your reappointment cycle, you have to query every 2 years unless you're signed up for continuous query. So just because you go to a 3-year doesn't mean you can now do a 3-year query. So that's something to keep in mind.
That's a good point. That's a good point.
Yeah, and because every hospital system is a little bit different. And then also too, I was thinking like, we do medical staff dues annually on April 1 with our fiscal year. Some places charge medical staff dues at reappointment time. So does this mean you're going to lose a whole year's worth of medical staff dues? I mean, you kind of have to think about all those things that might come into play because every hospital is different.
Yep. Yeah. Yeah. I'm sure the CFO, he's stakeholder.
Right. Right. I mean, money is important, especially right now with healthcare systems. I mean, everybody's very cognizant of the spending and the money that comes in. And another thing too, so we don't charge for initial or reappointment applications. A lot of hospital systems charge. So that means, you're charging every 3 years versus every 2. And it's just different things to keep in mind.
Yeah. Yeah. I'm sure the CFO would help you figure out how to adjust those fees to account for the 3-year versus the 2-year. There it is.
Yeah, I guess you could just increase. But that's another thing. Maybe you need to increase your reappointment fees or your medical staff dues. Yeah.
Yeah. All right. Anything that before we got started, you were thinking, I want to be sure I say that we haven't talked about yet?
I can't think of anything. I do want to mention that I reached out to a friend of mine that is in a pretty large healthcare system, and they have a combination of a couple of states, and both of the states that they're in allow for a 3-year cycle. And so I asked her, I'm like, have you decided to do this? Are you thinking about it? And she said they haven't really thought about it right now. There's some other things that they have to work on first, but that's just another example where if you're in a large hospital system, it's going to take a lot of strategic planning. It's not an easy feat if you're in a larger system.
Right. You have more key stakeholders that have to buy in.
Yeah, definitely. Yeah.
But once it is fully in transition, you feel pretty confident. I don't want to put words in your mouth, but do you feel confident that you'll see the benefit of the transition to a 3-year?
Yeah, I do. I definitely do. And for my department, it worked great. I have some of my employees that have been with me a very long time, and they're knocking on the door of retirement. So, I'm always thinking of ways to streamline processes because getting additional FTEs is sometimes hard to get. And so it just was the perfect time for us to work on that.
All right.
So hopefully it'll be fine. Well, I'll tell you in part 2, lesson learned. Hopefully I don't get fired.
We'll put on the calendar to get back together in 2027. How did it go?
Okay.
But so far you're smiling, so I take it as a thumbs up.
So far, all is good.
All right. Well, I really do appreciate your time today to share with others your experience about going to a 3-year reappointment period. Thank you very much.
Thank you.
All right.